All right, why don't we start off with something simple,
Yeah.
or maybe not simple, at least a definition. When you talk about invisible lesions, it sounds like something out of science fiction, like H.G. Wells. Um, what, let me tell you what my picture is and tell me if I'm wrong. I, let's say a patient has a biopsy and a pathologist gives it like a grade group score or a Gleason score. But then there'd been an MRI and nothing was seen on the MRI. So is that an invisible lesion or is it something else?
Yeah. I kind of look at it the other way around. So if you look at all other solid organ cancers, all of which are much more aggressive and much more lethal than prostate in terms of the likelihood of surviving if you're diagnosed with one, they're all visible lesions. So they exist when you can see them. You know, if you have a headache and you're worried about a brain tumor, you have a scan. If your scan is normal, nobody sticks a needle in your brain, and you're reassured and off you go. If you have an abnormality that looks as though it could be a cancer, you get a biopsy to confirm its nature. So, and the same goes for lung, for liver, for kidney, but for everything actually. And cancer exists when you can see it in all other solid organ cancers. Yeah. So we have to ask the question in prostate, does the same apply? Prostate is less lethal than all the cancers I've described. And it would be very, very odd if in the least lethal cancer, a subclinical phenotype, in other words, cancer that was non-visible, was somehow conferred risk. If it doesn't in the other more lethal cancers. So that's my premise, right? The reason you asked your question is that we have a habit as urologists of sticking needles into normal-looking prostates because we've never really been able to visualize the tumor. But of course we can now, and I'm just kind of challenging my colleagues whether now that we can see the tumor, we can change the way we both diagnose the disease and also think about the disease.
So by visualize, you mean MRIs or?
I actually, obviously, MRI is the mainstay, and that's what we know most about. But I suspect, modern ultrasound and PSMA PET will also do the trick.
Mm-hmm.
So it's imaging in its broader sense. Of course, when we speak about imaging now, most of us mean MRI because that's where we have the wealth of data. But there is new data emerging, that ultrasound may be as good, PSMA PET may be as good as imaging. And if that is the case, if that is true, what matters is visibility. And one could argue, well, why does visibility matter? Well, I think we know quite a lot. I mean, visible tumors are bigger. There are at least 100 million cancer cells present if you can see the tumor. If you can see the tumor's already evaded the immune system. It's picked up a blood supply. It can cope with a hypoxic center. So it's done all the kind of things that cancers need to do to progress. A few cancer cells that are not visible to our best forms of imaging haven't done that. And they've still got a long way to go. Lots of sequential mutations need to happen in order for them to overcome the immune system, et cetera, et cetera, et cetera. So I would argue that actually we just don't know the fate of non-visible disease. We obviously come across it when we stick a needle in the prostate.
Mm-hmm.
Sticking a needle in the prostate has been the main reason or driver behind overdiagnosis, which is a kind of recognition that not all cancers will progress if they were left alone. And so it seems very reasonable to suggest that actually what we need to do now is use imaging to identify a viable tumor mass and that's usually over 0.2, 0.5 cc's. That would be associated with 100 million cells as a minimum, and also have all the attributes that I've just outlined for you. And actually that the clinically meaningful entity that we're after is this tumor mass. An absence of a tumor mass should allow us to reassure the man, just like we do in all other solid organ cancers. I don't think it's that outlandish a proposition. It just seems so because we've always gone after non-visible disease, mainly because we couldn't image, right? And now we've got that habit that we still insist on sticking a needle into prostate that looks normal on MRI, ultrasound, or PSMA PET.
So when was this phenomenon first observed? And who observed the invisible lesion?
Well, I think we were able to discriminate invisible versus visible cancer when we could image the prostate. So, I think that's with the advent of MRI. MRI, became available to us in its modern kind of depiction, probably 2008. It wasn't until 2019 that NICE said that all men should have an MRI prior to biopsy. Why?
Yes,
to see if you
nice.
can identify a visible lesion and direct the needles at it.
And you said NICE, right?
Yeah, the National Institute of Clinical Excellence.
Okay.
And then all other agencies followed that. But that was April 2019, but largely based on our PROMISE and PRECISION publications.
I was diagnosed. I came through with a rising PSA. It wasn't all that high, but they did it to me, and I ended up, at least in Chicago, having an early MRI.
Oh wow, good.
Like in 2011. It was
That's early. That's early. Yeah, that's good.
But the results, two things happened. One is I ended up with tinnitus because the protection fell out, and I still hear the echoes even as I speak to you.
Oh my gosh.
Yeah, my brother's an audiologist, and he said it should have got better. Radiologist said it should have got better, but it never got better.
Oh dear. I'm sorry to hear that.
Not the end of the world, but I know people have that far worse. But something else happened. The biopsy showed a single core of 1 millimeter of Gleason 6.
Yeah.
And that was it. That was back in December 2010. In February 2011, I had an MRI. So it was sort of backwards of the way that we think about it now. And but it showed 2 lesions.
Okay.
One on either side. And I'm sure you knew Jerry Chodak, right?
Yeah, of course.
Yeah, Jerry was a friend of mine. He wasn't my physician. And so, I showed this to him. He said, I think this is an artifact. He said, you can choose to believe it, but I don't think it's accurate. So I ended up, after that, having 3 or 4 more biopsies and 1 more MRI, and the cancer never was seen again.
Right.
So is that invisible, or is that something else?
Yeah, it strikes me as it is. So it looks as though if the abnormality on your MRI came and went, it obviously wasn't a cancer. So it could have been some inflammation. Not everything we see is cancer. Not everything you see in the lung is cancer. Not everything you see on the brain is cancer. But it starts with a visible abnormality that's different from the background tissue. And then you stick your needle into that abnormality to ascertain its nature. So it sounds like yours was invisible, or would be invisible according to today's criteria. So in other words, the other way around, let's say you had your MRI, your second MRI, as your first MRI, and your prostate was deemed to be normal, today, probably nobody would have biopsied you.
Right. Yeah, I always thought it was a mistake, but
Yeah.
I was defined right then as a prostate cancer patient, and
Sure,
and
sure.
it's been on me ever since.
No,
You
no,
know,
and we did in those days. We thought Gleason 3+3 was lethal. These days, we're not so sure. And of course, Jerry Chodak was, who I knew quite well actually. He was always controversial, brilliantly controversial, but he was very good on this subject.
right,
Talked a lot about overdiagnosis and overtreatment.
right. He wrote some paper for New England Journal, I think
Yeah,
in 94, 95, talking about how a more conservative approach was needed.
yeah.
So maybe
No,
I'm
no.
an invisible man, who knows? But I haven't had a biopsy or an MRI in 8 years now. And I'm
Yeah,
just
no.
I'm
I
just
think I
following.
think yeah, and invisible disease, you know, is a lot less aggressive than visible disease. So we know a lot about this now. So visible diseases, there are more cells, there are higher grade, there are more truncal mutations, there are more mutations that are associated with mortality. They're phylogenetically different according to the evidence that's out now. So they're born differently. One doesn't beget the other. Yeah. And so this is as much, I mean, the evidence is not perfect because it's early days, but actually the evidence that is out there, which everybody can read, suggests that these are very, very different animals, as you would expect. Yeah. A visible nodule, a visible cancer never goes away. It progresses. It's just a case of when. We have no idea what the fate of invisible disease is. Some of it may indeed go away. We just don't know because we can't measure it. And when we rebiopsy somebody, you can't find it again, which I think was maybe your case, or you find more disease, but you don't know whether you're hitting the same bit or you're just finding another bit of cancer that you missed on the first go. So if you can't see it, if you can't measure it, I would argue that you can't do science on it. And I'm not alone in that. Lord Kelvin said
Right.
the same 200 years ago.
Well, how well accepted is the idea of invisible lesions?
Increasingly so. Um, you know, most um, most conferences now have a talk on invisible. There's several of us, who are talking about it. Um, so I think it's just kind of gaining ground. It's not the majority view as yet, and of course it's going to take a long time because we've been doing random biopsies for 40 years now. The history is interesting actually. So we used to go for visible disease. I mean, we used to go for clinical disease. So disease at the end. This was before ultrasound. You used to feel the nodule with your finger and then guide the needle onto your finger, and then very, very carefully deploy the needle into the nodule. So we used to do targeted biopsies of the nodule. Then came ultrasound. I blame Stamey for this, and we kind of moved to random biopsies. Ultrasound was never very good at identifying the cancer, but was very good at showing us where the prostate was. And then random biopsies held sway for 40 years until MRI came along. So the history is interesting. We used to target. So we're just doing what we did historically. There's just been an interlude of 40 years due to the advent of ultrasound.
Well, yeah, in the United States, at any rate, sort of a pre-biopsy MRI, I don't think the claim could be made that it's caught on. I mean, the best program in the country, in the state of Michigan, only 50% of their patients manage to get a pre-biopsy MRI. It's
Oh
going to be
wow, that's not great. I mean, I think everybody should have one. And most evidence-based practice policies would suggest that everybody should have one. You know,
happening
why,
is it's just
why
not
would you
happening.
not? You know?
I saw another study. Well, this year it looks like Michigan so far this year is up to 58%.
Wow, that's very low.
Probably, and then consider that the best in the country.
Yeah.
Um, but who are there outspoken critics against this idea of invisible lesions?
Yeah, maybe Andrew Vickers.
Oh, really?
Yeah, yeah.
Okay.
So you could speak to him about that. Yeah, he kind of it. You know, it's hard to be against it when it is the paradigm in all other solid organ cancers. Um, you know, it kind of odd to postulate that actually it's the subclinical, low volume, low grade disease that is the thing that kills us. Um, you know, when you see a man with early metastatic disease, with one met or two or three, what we call oligometastatic disease, and you look at the prostate is full of tumor. You never see a normal prostate in somebody with metastatic disease. If you look at the Memorial Sloan Kettering data on 1,500 men over 15 years, if they did not have visible disease, so if their MRI was normal prior to prostatectomy, the death rate was 0, no prostate cancer deaths after prostatectomy over 15 years. If there was visible disease presence, the death rate was 8%, so 1 in 10 over 15 years. So obviously they were treated individuals, but it pretty much proves to me that non-visible disease must be non-metastatic if nobody died after radical prostatectomy. Yeah,
Yeah.
it makes sense. There aren't many zeros in medicine.
I heard a talk that touched on this from Dr. Klotz a few months
Yes,
ago.
yeah. Yes, he will have covered this.
Well, he
Yeah.
brought up a genetic component and how to, and I don't, well, I'd like to hear your explanation of what genes have to do with this.
Yeah, well, the gene expression profile is very different in visible versus non-visible disease. You know, there are numerous papers that show that. And moreover, the gene expression that does exist in visible disease tends to have the gene expression that is associated with lethality, whereas that's not the case with invisible disease. The best paper on this is from Finland, and they looked at the gene expression in a very detailed manner, and it was them that they showed they compared visible versus non-visible versus benign. So benign was obtained from BPH specimens from resections, and the non-visible and benign were very close to each other in terms of gene expression. You know, they were indistinguishable almost compared to the visible lesions, which you kind of expect. You know they're different phenotypically. That means that different genes must be being expressed.
How do we
And
track
it's
down
very
that paper? Who's the author? Do you know?
yeah, Webner. Oh no, Webner is the Memorial Sloan Kettering paper. The author of the Finnish paper, I can give you in just a second. I will find it. Um,
You know, it's funny. I know Andrew pretty well. I've worked, turned into the Invisible Man. Did you see that? Here, look.
yes, you did. Yeah. I mean, if visible is a difficult term, we can say subclinical. Subclinical is probably a more accurate term, you know, and we find horrible subclinical changes. Let me. It's not letting me share.
Here, I can,
Okay.
you know, I just got a signal that you wanted to share.
Oh yeah.
I don't know why I went invisible.
Yeah. So can you see that? Yeah.
I can. Let me see if I can make it bigger. Oh, wait a minute. I see something there.
So, I mean, this is one of the early papers. This is 6 years ago. You can see that the visible lesions were much more likely to be aggressive. 4+5, 4+5, 4+3, 3+4, 4+3. The invisible lesions were all 3+3. But that's, you know, that's not. Let me see if I can.
I saw there was P. Lee or
Hang on.
Lie.
Yeah, that's not the main paper. Okay, that's the Memorial Sloan Kettering paper. That's Wibner, all right, and that shows that in the non-visible lesions, in other words, normal MRIs, there was 0 deaths, as opposed to nearly a 10% death rate where the MRI was positive prior to radical prostatectomy. 20% metastatic disease if the lesion was visible at baseline. Virtually 0, not quite 0, virtually 0 when the lesion was non-visible.
So is that the paper I should be looking for?
That's a good paper. But the really, really good paper is not on here. I've got the wrong. Let me get you a better.
So who wrote the very first paper on this?
I don't know. I don't think anybody the very first paper was probably the one I showed you, the 2018, actually.
I saw a presentation by Klotz in 2018 about this. So something must have preceded that. Or maybe it was, I think it was August 2018.
I think we started talking about it around then.
So, you know, Andrew Vickers.
Yeah, so this is the best. This is the best genetic paper.
Yeah, I gotta write that down. It's
Leto, TP et al. International Journal of Cancer, 2023.
Leto 2023 International Journal of Cancer.
Yeah, International Journal of Cancer, yeah.
Okay, I can track that down.
And what was interesting, visibles are blue, so they're clustered over here, and invisibles seem to be clustered kind of over here. It's not perfect, but you can see that phylogenetically they look very different. You know, you don't go from invisible to visible, for instance. Yeah, they seem to kind of have a fairly early kind of cutoff or diversion. Not as early as benign versus cancer, but not long after that. And this is the differential gene expression. So these are overexpressed and these are underexpressed in visible versus non-visible cancers. And then here's the so red is benign, green is invisible, sorry, and blue is visible. So you can see that benign and invisible are very close to each other in terms of gene expression. And visibles are really quite different, statistically significantly different.
You know, one line that I've heard from Vickers and Klotz and others, and maybe you even, you know, they say that Gleason 6 or grade group 1 or whatever you want to call it, it is, you know, it doesn't spread and it doesn't kill. And so it sounds like the same mantra with invisible lesions. So
Yeah.
is that to say that they're the same thing, or?
Well, if yes, so most subclinical disease is Gleason 3+3, but there is also a small amount of Gleason 3+4, a little bit of 4+3, and so it goes wider than Gleason 3+3, but 3+3 is the majority of invisible disease. And obviously, if you have invisible disease and that leads you not to stick a needle in, you avoid overdiagnosis. Yeah. So if you only stick a needle in the lesion, you can get your Gleason 3+3 diagnoses down to 1% of the patients that are being exposed to MRI. So basically, you get rid of overdiagnosis. Well, it goes down to 1%. So essentially, Gleason 3+3 disappears if you stop looking for invisible disease.
So, how do you do that in the real world? I mean, there's no guidelines that say to do that, are there?
There are, yeah. The nice April 2019 said, consider avoiding a biopsy if the MRI is normal. I've never biopsied normal MRIs, and that allows you to avoid about a quarter of the biopsies that you would normally do. In Europe, that's 250,000 men a year. We do 1 million biopsies a year in Europe. You do more in the States. 250,000 of those can avoid a biopsy. If you don't stick a needle in indeterminate signal with a low PSA density, you can add another 10% to that, maybe 15%. So you can get up from 25% to nearly 40% of patients who don't need a biopsy.
So
And that's at the low end of the risk spectrum, right? So suddenly you're halving or nearly halving the number of biopsies that you're doing, and reducing obviously the harm of biopsies, etc., reducing overdiagnosis, etc. At the high end risk of the spectrum, we're seeing something very interesting, is that men are asking to avoid a biopsy if there is a very high likelihood that they're going to have cancer and need an operation. Why? Because they don't want to delay the operation. They don't want to risk the biopsy spreading the disease. And the Germans have done this and published. The Chinese are doing it and have submitted their paper. Certainly the German, it's too early to talk about the Chinese, but there are 2 German studies that show 100% sensitivity for clinically significant disease, in men who are MRI and PSMA PET positive prior to radical prostatectomy. So if there's 100% likelihood that you're going to have clinically significant disease, you could argue, what is the role of biopsy in these men?
Do you make a distinction between invisible lesions and remission? Klotz talks about remission. I don't know if you do, but are the two
remission is usually used as a response to treatment. And yes, after focal therapy, I use imaging. If there's no sign of disease, I don't stick a needle in their prostates. So I use imaging to derive remission, as we do in all other cancers. You use for lymphoma, leukemia, most other cancers, you use CT or PET scan in order to derive remission or otherwise. Yeah, so that's not unusual.
And I can't remember the figure. Maybe it's 25%. With MRI, the cancers are missed in 25% of cases.
Well, you could argue that they're not missed. If you don't care about invisible disease, they are quite appropriately overlooked.
So
I think this notion of missed invisible disease is spurious.
But is the percentage that I mentioned about right?
It depends. It depends how you biopsy. So PROMISE is probably the best study to tell you, because there's been no cohort that's been better biopsy than PROMISE. PROMISE will give you the yield. Trust biopsy had a 48% chance of identifying clinically significant disease. MRI had a 93% chance. You know, so the negative predictive value for clinically significant disease was in the order of 98%, 97, 98%. Yeah, our time is up. I've got another call. It's gone past
Okay.
very quickly.
Okay, well, if I have some other question, I'll send you a note. And let me mull this over and I'll be back to you.